And like Megan said, I'd like to thank everyone as well for participating in the webinar. So this morning we're going to be discussing traumatic brain injury in elders, traumatic brain injury in older adults. So we're going to talk a little bit about brain injury and where to access services and how to work with consumers, clients, patients that have sustained a traumatic brain injury. So I'm going to just start by giving a brief overview of my organization, my agency, the Brain Injury Association of Massachusetts, for those who might not be aware of, might not have heard of us before. We're a private not-for-profit agency. We started in 1985 through grassroots, or a little bit before that actually, as a grassroots operation. It was several mothers sitting around a table, essentially, and at the time there were no services at all for people with brain injury, really in Massachusetts, but also on a national level. And the mothers of the children that they had experienced brain injuries themselves through car accidents, and one in a sports injury, and they created an organization that advocated on a state level for the services that now exist. And as I mentioned before, we will get into some of the state agencies and resources that exist now for brain injury, but just wanted to give you that short little snippet of our past. Today we are still doing a lot of advocacy on a state level, and we also have 3 other pillars that we stand on in terms of how we work to improve the lives of brain injury survivors and their family members, and we do that through prevention, education, and of course our advocacy and support. So we have a lot of prevention type programs that we do. We've done falls prevention in the past. Recently we're involved with a very successful program called Think Ahead, where we go into classrooms across the state and talk to kids about things like helmet, playground safety, sports concussions. We have a thriving education department, a very large annual conference coming up at the end of March that I'm both happy and disappointed to say that the registration is closed, so unfortunately I can't extend the invitation to anybody this morning, but hopefully next year. We were super surprised that we sold out in the beginning of March. We do some clinical trainings, an ABI clinical series, and we have a certified brain injury specialist curriculum that we're going to be doing this year as well. And then in terms of support, this is our closest tie to brain injury survivors. I'll reference it later when we're talking about resources again, but we do have a network of support groups, over 50 in the state, across the state. Some of these support groups are specifically for brain injury survivors, some specifically for their caregivers. We have groups that are mostly men, for mostly women. We have a newer LGBT group. We have a young adults group. We experimented with some groups specifically for people that were in their older years. So our support groups are really something that our survivors get a lot out of. And then we do information and resources, which I'll again come back to a little bit later on. So I'm just going to really briefly introduce myself in terms of the grant that allows me to present this webinar and other training opportunities to the community. It's a federal grant that we were given through the Administration of Community Living, and the grant was given to the Mass Rehab Commission, the Massachusetts Rehabilitation Commission, and we're working alongside the Executive Office of Elder Affairs and the Brain Injury Association. These 3 entities have been promoting efforts to spread awareness on brain injury, specifically in older adults, to providers that work with older adults in Massachusetts. So this is the name of the grant on this slide, and the goal is really to maximize the services that already exist. So we didn't create any new services with this grant, but rather we're trying to make sure that the 2 different worlds understand each other and can communicate in terms of what's already out there for brain injury and what's already out there in terms of the elder service delivery system. And I'm not going to get too much into this slide, but if you're interested, I'd be happy to answer specific questions. But I just wanted to again reiterate the partners on the grant, specifically the partner agencies through EOEA is what we know as the Aging Services Access Points and also the Independent Living Centers. So we started by training those agencies, and now we're branching out to home care agencies, to hospitals, to skilled nursing facilities, to assisted livings, and trying to police, fire, anybody that really comes in contact with older adults. But this just shows our first year. And this small chart is just highlighting the relationship between the three agencies and hoping that we're enhancing what's known across the state as a no wrong door model. So call any one of these entities, brain injury at MRC, BIA, or the network of Aging Services Access Points and Independent Living Centers, and you'd be able to get the answers that you're looking for the patients that you're working with. Okay, so I'm going to start the educational piece of our morning, and I just want to let everyone know this is a very brief overview of brain injury in older adults. We could talk forever about just brain anatomy, so this is going to be very surface level information, and I'd be happy to share opportunities for further learning if you're interested. So today we're really going to just do a brief overview of brain injury. We're going to talk about the incidence data specifically in Massachusetts and also at a national level. We're going to look a little bit at the impact to elders. So why is this an important topic to focus specifically on for our aging population? And then talk about how we can go about identifying brain injury in our clients, our patients, and then strategies for working with brain injury, and again, I'll share some continuing education opportunities for you if you're interested. So I'm going to start by assuming that there's people that are listening in that have not a lot of knowledge on brain injury. So I'll give a foundation, sort of a foundation for what we're talking about today. There's the umbrella of acquired brain injury, and I say umbrella, and I have a nice little chart and then one of the next slides coming up that will just highlight the fact that this is an umbrella term. But acquired brain injury really is any insult to the brain that has occurred after birth, and it is not hereditary and not congenital. So what does this mean? Sometimes it's helpful to think of what's exclusionary. So what is not a brain injury? What is not an acquired brain injury? Something that occurs during birth, like cerebral palsy, could be a birthing injury, happened in the birth canal. That's not considered to be an acquired brain injury. Hereditary, something like Tay-Sachs disease, is not considered to be an acquired brain injury because it's a hereditary condition, and a congenital brain defect, which would be something like a recent example would be the scare of the Zika virus and causing microcephaly in a certain number of babies that were born to mothers that had contracted the Zika virus. So that's an example of a congenital birth defect and not an acquired brain injury. Everything else is. So here's a chart I was talking about. Again, acquired brain injury is the umbrella term. I think, and I just want to highlight this because I think a lot of people, when they've heard people speaking about brain injury, we sometimes hear ABI versus TBI, but really it's non-traumatic brain injuries versus traumatic brain injuries. The wording here is kind of funny because if any of us have ever come across, which I'm sure we all have, someone that's had an quote, non-traumatic brain injury, an example would be a stroke. We know it's a very traumatic, life-changing situation for a person, but the way that what we call these two types of injuries really has more to do with how the injury has occurred, and I'll be talking about that in the next couple slides. So again, I really like this chart because it has that acquired brain injury at the top as an umbrella, so we can highlight that, and we'll go into the subcategories in the next few slides in more detail. So examples of non-traumatic brain injuries. Non-traumatic brain injuries are referring to anything that is happening internally, an internally caused injury. So an example of that would be infection, something like meningitis or HIV or the West Nile virus can cause non-traumatic injuries to the brain. Neoplastic, so that is tumor, cancer. We do have a fair, at the Brain Injury Association, we do consult and provide information and resources to people with all types of brain injury. Cancer is such a huge world in and of itself. We often would direct people back to something like the Brain Tumor Association because they would have even more resources than we would know about, but definitely a big category. Also, the vascular injuries. This is the second leading cause of acquired brain injury next to traumatic brain injury. So traumatic brain injury, the leading cause of all acquired brain injuries, and then the vascular, specifically stroke, is the second. So obviously we as providers that I'm sure you've seen a lot of patients, and maybe even in your personal life, people that have survived stroke. Another example of a vascular injury is an aneurysm. Metabolic. So anoxic brain injuries, unfortunately pretty common. We have still in the United States, I think the prevalence of cardiac arrest and cardiac disease is high, and we see a lot of brain injuries, anoxic brain injuries resulting from heart attacks, and also an anoxic injury could come from something like a near drowning experience. So when somebody had been younger, for example, and even when we think about an older adult, we kind of think about the whole spectrum of a lifespan. So somebody that's older might have had actually a metabolic, an anoxic brain injury when they were younger due to a near drowning experience. A suicide attempt could lead to anoxic brain injury. And I think what we're seeing more and more, especially in young people and in Massachusetts, but really all over the country, unfortunately, is the epidemic level issues that we're having with heroin and opiate overdose. And those overdoses often cause lack of oxygen to the brain, which is causing severe brain damage. I had somebody call a couple of weeks ago, actually. Their daughter had overdosed on heroin. It was a sad situation, and the daughter was living in Colorado, and the dad was trying to figure out a way to get her back to Massachusetts because we have, even though we have a long way to go, we have some of the leading services in terms of rehabilitation for people with brain injury, and he was trying to get her back here so she could get the rehab that she needed after this significant OD that she experienced. Neurotoxic injury, so this would be something like lead poisoning, also carbon monoxide. I think that both of these, for, again, older adults, sometimes if you're thinking about someone's past history, this is something that older adults are maybe more likely to have experienced in their younger years because we're getting a little bit better at preventing neurotoxic injuries. We have carbon monoxide detectors, and we have laws that are surrounding lead paint in particular, especially in our state. And so now we're going to look at specifically traumatic brain injury, and the grant is focused on traumatic brain injury. This is the leading cause of acquired brain injury. And a traumatic brain injury refers to any external force to the head. So within traumatic brain injury, we have a couple of different subcategories. I focused here on two specifically: a closed head injury versus an open head injury or a penetrating head injury. A closed head injury is much more common. The skull is a very difficult bone to fracture. It's a very hard bone for good reason. It protects our brain. But if there's no skull fracture or penetration, then we refer to this as a closed head injury. This injury could be more damaging to the brain in some cases because of the way that our body heals. So if you think about, somebody healing from any wound or illness, there's a certain amount of swelling that would come to the area, and the same thing happens with the brain. So when the brain is injured, swelling can occur, and that swelling can cause secondary injuries after the initial impact. So sometimes in the ER or the ICU, a doctor will make a decision to remove a piece of the skull in a craniotomy and place the piece of skull into somebody's abdomen and allow the brain to have a way to swell without further injury, and then when the swelling goes down, they'll remove that. And it's sort of like a pretty signature scar that you might see on someone's head that's had that part of their skull temporarily placed in their abdomen for that purpose. It's sort of like a half moon scar that you might see on somebody's head after the fact, but that's really, again, to save the brain from having secondary injuries. And inside our skull, it's not smooth. There's a lot of bony ridges. And that also leads me to just say a word about what's called a coup contra coup injury, which I'm not sure if people have heard this term before, but it really refers to the phenomenon that we think of as whiplash, a whiplash event. And before I worked in the brain injury world, I always thought whiplash was something that really just made your neck feel sore, and it was a neck, more of like a neck muscle type of a injury. But the actual event of whiplash causes what's called a coup contra coup injury, or an acceleration deceleration injury. And an example of this, the best example of this, and the most common, would be a car accident. And if you're driving at a certain speed and then the car comes to a complete stop, then and the seatbelt will hold your body in place essentially, but your head is going to go forward and then go back, or if you were T-boned, then your head would go to the left side and then the right side, and sort of ping pong. If I was with you in person, I have a little brain that I use to kind of ping and pong from one side of my hand to the other to show that the movement of the brain continues to happen even after the body stops. The body comes to a stop, but the brain continues to kind of bounce within the skull. And that can cause a significant injury. So even if you don't hit your head in a car accident, but it's a significant accident where there was high speed involved, then you might feel some symptoms of what might be a concussion and possibly even a moderate type injury. So it can actually be a pretty significant injury, and that's again because of the bony ridges that exist within the skull and the process of the brain hitting the inside of the skull on both for example, if it was a front to back, the frontal lobe, and the back part of the brain hitting the back part of the skull and injuring both of those parts of the brain. So I like to really highlight that because I think a lot of people don't realize that and don't recognize that people could have a brain injury from a car accident without having hit your head. Another example I like to highlight is, especially for an older adult, if you have a fall, if somebody were to fall, even if you were to catch yourself on the ground, that motion of falling from a standing position and to the falling position, that could potentially have that same whiplash motion occur. So somebody that's an older adult and even they say, oh, I fell out of bed, but I didn't hit my head, but they feel there's still some cognitive changes there. They're still feeling sort of out of it, or however they might describe it. It could be the same type of injury. And lastly, unfortunately, which I won't get too much in today, I don't really like to talk about, I'm sure nobody does, but shaken baby syndrome is another a good example of the coup contra coup injury. And people in their past, again, older adults in their past, if there's a history of domestic violence, if there's a history of violence in somebody's childhood and having been abused as a child, then possibly these could have been injuries that occurred before and are now affecting them. So just some things to think about. And then back to the second subcategory, which is an open head injury. So this is, or a penetrating head injury, where there is a penetration to the brain or a skull fracture. And this is much more common. We would see this more commonly in events such as a stab or a stabbing or a gunshot wound, because it is pretty difficult to get through the skull. There's also some other types of injuries. There's what's called well, actually, I'm going to save that for just a second, because when we move on to ways in which people can get a brain injury. So here we are talking just a little bit about, so people kind of are familiar with how are people sustaining brain injuries, what are the leading causes these days, and really we break the causes down between what we would call unintentional and intentional. and unintentional are really accidents. So accidents in the past, I think really people would identify brain injury as being something that somebody that was 18, 19, involved in like a DUI, wasn't wearing their seatbelt, and was in an MVA or motor vehicle accident. And I think that a lot of people sort of relate that type of injury to a younger population. But really what's happened now over the years is that motor vehicles accidents are no longer the leading cause of brain injury. We've really improved safety in our cars. You know, we have airbags, we have side airbags, we have seatbelt laws, we have more excessive punishment for different types of charges. And now falls has really taken the #1 place for the leading cause of traumatic brain injury. So, and that's really why I'm here talking to you this morning, is because we, I think as providers, know that falls is a really common occurrence as we age. There's a lot of different reasons why we're at higher risk from falls, which we'll talk about in a couple of minutes. But again, just wanted to stress here that while car accidents were the leading cause, falls has really taken its place. And this is actually in all age groups. So we're talking about older adults, but most of this information can really apply to all age groups. But falls are the leading cause in every single age group. They just happen to affect people, the two different age groups the rates are the highest in two specific age groups, the 0 to 4, which, as we know, or people that might have young kids or young grandkids might be aware that 0 to 4-year-olds are still learning to walk, essentially, so they're at a little bit higher risk for falls, and then the 60-plus category because of some factors that we'll talk about in a minute. And then we also have sports and recreational activities, and this we've really seen gone down too because of the way in which we look at sports-related injuries. I think if anybody's a football fan or a hockey fan, I'm sure that you have seen some of the hits that occur, and also some of on the news following some of the national initiatives to kind of take a spotlight to the issues of football at all levels and other contact sports at all levels, and making sure that we keep kids specifically safe in just knowing the risk of these sports and taking certain steps to prevent injury. So, and just an example of this, in Massachusetts a few years back, we instituted rules for children's football and soccer, and I'm not sure if it's all sports. I'd have to, if anybody's interested in more information about this, then I'd be happy to kind of look into it. But basically we instituted sideline testing, so people would be able to, not just nurses or doctors or EMTs, but even coaches would be able to utilize a short cognitive test to determine whether somebody was at their baseline after an injury or whether they looked like there was some very slight cognitive changes which might indicate a concussion. Because in the past we saw, you know, if somebody got hit in football, if somebody was tackled and they hit their head in some way, then we might not really think it was worrisome at all if they didn't lose consciousness. But now we know that people can that a concussion should be taken seriously, and if somebody does have a concussion, then we really need to pull them out of the game to prevent what would be known as getting a second concussion and having the risks that go along with that. So, which again, I could go on I am sort of going on a tangent, but I could go deeper into a tangent on this specific topic. But if you're interested in more regarding the sports and recreational activities, I'd be happy to share a lot of information with you. But for today, I'll move on. We also have work industrial accidents. I think this another subcategory that's really we've seen people be able to, we're preventing these injuries more. You know, I think with OSHA laws and just safety and on work sites and in the work environment, hard hat laws, we've prevented a lot of these injuries in a way that we didn't prior. And again, oh, and this is where I was going to come back to. There's another subcategory of injuries which is known as a crush injury. So that would be an example is that the neuropsychologists give in our clinical trainings that we do as part of the grant in the community. The neuropsychologists talk about some of the worst injuries they've seen is like if somebody's working in an auto body repair shop and some of those doors aren't like our garage doors at home where they have the feature that they won't come down on you. They might continue to come down on somebody, and they talk about some severe injuries they've seen where somebody's head is injured severely by one of those industrial garage doors at a body shop. And then we're just going to move on to talking about intentional causes of TBI. So these are really our cases of attacks or assaults. So I kind of mentioned before thinking about the spectrum of somebody's life, especially if they're an older adult, and maybe looking into or thinking about a past history of domestic or dating violence, personal violence, or child abuse in someone's past. As we mentioned before, there can be an anoxic injury due to a suicide attempt, but also a traumatic brain injury due to a suicide attempt, maybe if there was a gun involved, something like that. Homicide attempts, and violent criminal behavior. You know, we see traumatic brain injury at an extremely high rate in our correctional systems. So people that are currently in prison or have been incarcerated in the past have this group of people we see has an extremely high, in terms of their population, the percentage of people who are living with a TBI that are incarcerated is really much higher than the population of adults that are not living in prison. So we see that, and I think there's a few factors that go along with that, but really with certain types of criminal behavior puts people at higher risk for brain injuries. Again, if you're interested in any of these specific topics, I'm more than happy after to share what information we have or reading or something like that if you're interested in looking more into statistics and things like that. And then lastly, military combat. I think that this is really significant in the last few years because of, decade plus now, where we've seen our veterans come home from Afghanistan and Iraq, where the signature injuries have been said to be the traumatic brain injury along with post-traumatic stress syndrome. So with these two particular conflicts, war conflicts in, again, Iraq and Afghanistan and the wars that started in the early 2000s, we've had a lot of veterans overseas who have been exposed to what's known as improvised explosive devices. So people are sort of making these homemade bombs out of shrapnel. Unfortunately, we saw it really close to home with the marathon bombings. It was essentially the same thing, an IED, which they were sure to put a lot of metal shrapnel into those bombs that they created, and it's really can be a quite devastating blast because of the different types of injuries that can occur. We have men and women that have come home from having an injury from the actual blast, so the actual blast itself can cause an injury, and then secondarily there can be injuries from the shrapnel, can cause penetrating injuries. So when the bomb goes off and the metal disperses, people have had pieces of the metal that have penetrated their skull in some cases, and then there's the wave of energy that occurs from that bomb can actually cause people to be lifted off their feet. You know, you think of the movies, and it's much more devastating, obviously, than the movies, but really if you imagine somebody being lifted off their feet and thrown against a wall or the ground or something like that, and then sustaining a head injury from those cases. So I saw some statistic, I wish I don't have it off the top of my head, be happy to share it with you after, but on how many of these veterans coming home from these two wars have sustained this type of injury in terms of all these traumatic different types of traumatic brain injuries. It's really staggering. But then in obvious, for people who work with older folks too, there's going to be signature injuries from, or different types of injuries from every conflict that we've had in the United States. So there's, and people obviously that are from other countries as well and have lived in other countries. But in terms of American wars, we get calls from Vietnam vets, we get calls from Korean War vets, but in Vietnam it could be something like poisoning. Agent Orange, exposure to Agent Orange would be an example of like a neurotoxic injury. Guys that were involved in World War II even, or the Korean War for older adults. So, and sometimes we don't think about, over the years, hopefully we've been improving the way in which we treat veterans when they come home in terms of what services aftercare services they're able to get, but sometimes we don't. When we think about an older adult, they could have had an injury in a conflict and not have had that identified or treated. Okay, so I just want to kind of briefly talk about levels of severity in terms of brain injury. So the medical community specifically categorizes severity in TBI based on loss of consciousness. So there's something called the Glasgow Coma Scale, which I didn't include this in this presentation because we could really expand upon it, but again, this is a really brief overview. But basically, the medical community would break down the levels of severity between mild, moderate, or severe. And mild is going to be our most common brain injury. So this is what we see most often, and a mild injury is also referred to as a concussion, which I think surprises a lot of people. I know I've been mentioning concussions on and off through the presentation, but even, I've spoken to a group with mostly nurses or mostly medical people in the medical field, and there's always several people that are surprised to hear that a concussion is a traumatic brain injury. And as I mentioned before, two concussions back to back can cause a rare but very dangerous situation that can sometimes lead to death. So that's why we're so concerned about kids coming out and being safe after concussion. And we know that multiple concussions are cumulative, cumulative, meaning that after, which we can sort of chat. I think we'll have a minute to chat about that later as well, but something that we see as know now to be chronic traumatic encephalopathy, which is the phenomenon that happens after years of repeated concussions and what the brain looks like after years of repeated injuries. So we can get into that, like I said, in a little bit later on. And then moderate and severe are less common. The way that the categorizations of brain injury, this only has to do with how a doctor or somebody in the medical community would initially diagnose. It has nothing to do with how a survivor's life would be impacted. So somebody with a mild injury or a concussion might have long lasting side effects or symptoms, so they might struggle for years and years or really a lifetime of migraine headaches. They might have nerve pain, they might have dizziness, and then somebody could have a really severe injury where they had to relearn to walk and relearn to talk, and they spent time in many months in a ICU in a rehab facility, and they might make what would appear to be miraculous and almost 100% recovery. So we really can't predict how an injury is going to affect someone's life. So just wanted to stress that, because when we're working with people, just because they had a mild injury doesn't mean their life is impacted mildly. So here's a little chart. We'll just segue to how common is this? How common is brain injury, and both on a national level and on a state level. So I have included this graphic that I've gotten from the Centers for Disease Control and Prevention from brainline.org, which is a good website if anybody's interested, especially to give to family members and brain injury survivors to kind of poke around. There's a lot of good articles and things on that website. But anyhow, this chart is just a really neat way to take a look at the vast majority of people, that 2.2 million people, are going to be treated and released from the ER. So all those blue people are not going to even spend time in the hospital. They're not even going to be admitted. And then the smaller orange amount, 280,000, will be hospitalized, and only about 50,000 will die, which is the really good news. But the vast majority here, with the exception of that 50,000, all those people are going to need services. So that's where home care comes in, and that's where resources and services for brain injury why they're so important, because it's really something that people will be living with for a lifetime possibly. And then I just created this little pie chart. It basically is the same information that people have in Massachusetts. The vast majority, the 80.7% of people, will sustain a TBI and visit the ER only. So we're going to assume that most of those people have what's diagnosed as just a mild injury, a concussion. And then the 16.3 will be serious enough to be admitted and possibly spend some time in rehab, and then a very tiny percent will pass away from their injuries. We're keeping people alive at a much higher rate than it used to be that in a car accident, if someone sustained a moderate or severe injury, their likelihood of surviving that car accident, for example, would be extremely low. But now we have, again, all the car safety measures, but we also have, and in Massachusetts we're so lucky, but we have med flights, and we can get to level 1 trauma centers in minutes, really. So we can also do a lot of life-sustaining support right on the scene. The paramedics are able to support life right on the scene. So we're keeping people alive, and again, they're going to need services when they're home. So ADA, back to the falls that we mentioned before, and I'm going to talk a little bit about older adults specifically, and why is it important to think about this population. But I wanted to start with this fact, which is pretty staggering, that 88% of all TBI-related hospital stays are associated with unintentional falls. So that's a huge number, 88%. And again, this is specifically for all age groups. So you could see how common falls are and their strong link with brain injuries. Some stats for traumatic brain injury in elders, specifically in Massachusetts, and what we call, when I say elders here, I mean 60 plus. So we have about nearly 16,000 people over 60 are sustaining TBI in each year in Massachusetts. And falls representing the leading cause of TBI in adults 60 plus. And then what we see is really as people age, so the third statistic about 70 plus, as people even age into their 70s and their 80s and above, the risk for falls just keeps increasing. And then the last statistic, which I didn't mention in the beginning, is the grant is really focused on 2 areas of the state, the Metro West and the Northeast, because for some reason, and I'm not going to spend too much time on this because we don't really know why, adults in the Metro West and the Northeast have the highest rates of TBIs in the state. We honestly don't really know why. The neuropsychologists have a couple of guesses. There's a really high, maybe people access healthcare more in these 2 regions. There's a high prevalence of 3-level houses in these areas, triple deckers. There's a high prevalence of basement laundry level. There are a lot of people, older adults, fall down their stairs trying to do laundry, something like that. But we really don't know why. But I think that's kind of an interesting thing. So if anybody works in those areas, there's a slightly higher rate. And then for older adults, there's definitely some special considerations when you're talking about an older person, as it would be for any condition or any injury that would occur. There's going to be some things that are specific to this group. So the diagnosis and the rehabilitation and the outcomes are really complicated by factors that are specific to the age group. I think one of the biggest things is comorbid medical conditions. Sorry, one second. 15 minutes. Sorry about that. So there's a lot of comorbid, more comorbid medical conditions than people of other ages might have, along with the injury that they sustain, meaning that we have a higher prevalence of blood pressure issues, of cardiac issues, of diabetes. And these would be conditions that might complicate the outcomes in the way that somebody would rehabilitate after a brain injury. Also, and this would go for people of all ages depending on your health too. So again, when we think about how somebody is going to heal and how brain injury is going to play out in terms of someone's lifetime, the medical conditions would have a part in that as well. And then when we think about polypharmacy, we're doing one of the tracks for our conference is, which I mentioned earlier, the annual conference that we're having. Somebody is doing a presentation from the Mass College of Pharmacy and Health Sciences that has to do with medication, the link between medication and falls. And when we think about polypharmacy and people understanding how certain medications interact with each other, and also the side effects of medication. So oftentimes when I'm out in the community talking to the older adults, because I do a version of this presentation for seniors in the community, I'll really emphasize the importance of talking to doctors and medical providers about medications, reviewing medications, making sure that all providers know about, if there's different prescribers, making sure everyone's on the same page, and really understanding how those medications affect the patient, but also how they interact with each other. So something like a blood pressure medication, a lot of people aren't even aware that that can cause dizziness or even fainting if there's a sudden decrease in blood pressure or getting up in the morning. And if you are on blood pressure medications or something like nitrates, making sure you're sitting down while you take them. Just small things like that that I've been spreading to seniors when I'm talking to them in the community. So thinking about stuff like that. And then how drugs and alcohol affects the older population as we age. These substance use is going to impact our bodies in a lot different, in a very different way than it would when we were younger. So having conversations with people that might have been using alcohol or substances for their life and kind of knowing what their limit was or knowing what their tolerance level was, but as people age, this is affecting people differently. So it can affect the outcome of a TBI, and it can also lead to other TBIs. Substance use definitely increases people's risk for future TBIs, and what the stance of the providers nationwide really take in terms of the brain injury field is no amount of alcohol is safe with a brain injury. And I do have some information, which I'll talk about later, that I'm happy to mail people if they're interested in a brochure that's specifically on substance abuse and depression in older adults as related to brain injury, which is kind of interesting. And then lastly, elder abuse. So I think that, actually I didn't mention in the beginning, but prior to this role I worked in elder protective services, and I saw certainly cases of abuse, but I think what was much more common was more situations of neglect where caregivers it wasn't made clear, or caregivers didn't understand, or caregivers were stressed, and they were, and I'm sure people have seen this in their work in home care agencies, that people are told by the doctor that their loved one needs a certain level of supervision, and not really understanding how important that is, and leaving somebody unsupervised, and that leading to another fall or something like that, or not following through with some recommendations for things that are sort of easy to change. Again, I talked to people in the community about doing home modifications, so accessing funds that are available to older adults through Medicaid or Medicare, other funding streams, where people can really make a lot of modifications in terms of grab bars and rails and shower modifications, things like that. So I think these things are important to think about in older adults. So I'm going to just segue and we're going to really briefly talk about a screening tool. So we've talked a little bit about what brain injury is, how prevalent it is, but as providers, sometimes, this stuff isn't necessarily on it's not on the chart. It's people haven't been identified as having a brain injury. And as someone that's worked with older adults in a couple of different capacities, I think what I've seen or what I've observed is, somebody has a fall and they go into the ER, and along with maybe having a head injury, they also broke their wrist or they broke their hip, and the doctors really focused on healing that broken bone that's occurred or something that you can visibly see. And a brain injury is often, we often refer to it as an invisible injury, because if there's no open wound or laceration, then we might not assume that there has been any injury that's occurred. So it's often overlooked. So we've been spreading this screening tool. It's not a diagnostic tool. It's a screening tool. So any level of professional or non-professional can use this screening tool. And it's really just to identify people that might have a brain injury and get them back to their doctor to talk about it. So I'm just going to, if you just bear with me for a second, oops. This is basically it, and then I'm going to, I had, Megan was kind enough to email out, I believe, beforehand, some handouts. So we'll take a look at the screening, the HELP screening tool for TBI. It was a PDF. I'm just going to get into that screen. Okay, so this is the bigger version of it, and you can just print this out and use it in any capacity that you feel would be appropriate in your work. But basically, just wanted to really quickly review it. It's the easiest tool that we could find across the nation that people are using for brain injury screening. And it's basically, have you ever hit your head or been hit on the head? Have you ever been to the emergency room or the hospital or been seen by a doctor because you hit your head? Have you ever had a loss of consciousness or experienced a period of days of altered state of consciousness? So not just did you black out, but did you feel did you see stars? Did you feel dizzy? Were you out of it? That kind of thing. And then what problems have you experienced since you hit your head? And this is so contextual because, as we know, it's kind of reads like a pharmaceutical commercial. Call your doctor if you've experienced headaches, dizziness, anxiety, depression, difficulty reading, writing. So this would be really contextual, is have these problems been, can we pinpoint that these problems had started when you hit your head? And then the S for, are there any significant sicknesses? This will catch people that have not had a traumatic brain injury, but rather on a non-traumatic acquired brain injury, like we were talking about the internally caused injury. So have you ever had, have you had seizures? Have you had brain cancer? Have you had West Nile? And then basically, I'm not going to go over the whole, it's pretty self-explanatory, the screening, how to score the screening tool. And really, if, in your work, if you don't have to get this technical about it, it's sort of just a good guide to have a conversation with a patient or a family member of a patient, and then say, you know what, I think that you might have had a brain injury when you hit your head, and I think that this might be something that we need to bring up to the doctor, because in older adults, as we know, as medical providers or care providers in any capacity, that older adults, there can be changes in cognition for a lot of different reasons. So the first thing that people might look at is, does this person have a UTI? Is that why cognition has declined? Does this person have some a vascular or other type of dementia that's starting? Does this person have early onset Alzheimer's? Is this person been in the hospital and maybe there's some delirium? So there's a lot of different reasons why someone's cognition could be, are their meds off? Why someone's cognition could be off. But if we can identify that there was a hit on the head or some injury to the head, then we can get that information back to the doctor and make sure someone's diagnosed properly and that they're able to access all the services and resources that they can get based on that. So I hope that makes sense, and please feel free to ask me questions about that in a minute. So this is just basically the suggested protocol that I just went over. Basically get back to the doctor and so that you can talk to them about how to adjust any kind of service plan that in terms of working with brain injury. So for today, we're not going to go over this whole map of the brain. I included this in here because I think it's really important to see the brain and understand where an injury occurs is going to impact somebody in a very specific way in terms of their cognitive functioning or their physical functioning or their emotional functioning. So depending on where that injury actually happens, and again, if it's a type of injury like a coup contre coup, it could be affecting two different lobes of the brain, or if it's a stroke, it could be affecting 4 or 5 different parts of the brain. So it's something to be aware of and to think about, because this is also going to be what the symptoms that you're going to see. So just a brief example is that frontal lobe is really our what we would call our most human piece of our brain, where all of our executive functioning occurs. So if someone injures their frontal lobe, which is common place to fall and hit your forehead, a lot of times a stroke would affect this part of the brain, then we're really going to see a lot of difficulty in day-to-day functioning, like attention, motivation, emotional regulation, problem solving. So again, all these what we know as higher executive functions, we're really going to see a change in that. People that have had an injury to the temporal lobes, a lot of times this is where our language is based, and specifically if there could be some aphasia or communicative disorders that occur as a result of these type of injuries. And then the cerebellum, I think another good part to highlight, this is like on the back lower part of our head, again, super common part to injure when if we fell, if you fall backwards and you hit the back of your head. And unfortunately, that's where balance and coordination is, and also skilled motor. So if these functions are damaged, then you're put at higher risk for a secondary brain injury. And when we're working with clients, really, again, thinking back to when you're working with a patient that's had a brain injury and thinking about where in their brain they were injured and how that impacts them, what are some small things that we can do to really make accommodations for someone with a brain injury, at least be thinking about some things that we can do. People might have fatigue, they might have headaches. Fatigue's a really big one. Brain fatigue's a real thing. A lot of people especially with caregivers, I think, and family members, sometimes it's difficult for people to understand, oh, you look fine, because we think of a broken arm, cast for 6 weeks or whatever it is, and then you're okay. A brain injury is really very different, because the way that our brain, we can't make any new neurons, we're just making new connections within the brain. So it could take a long time for the brain to heal, and it's definitely not as direct of a process as again, a broken arm or something like that, and people really need to rest. So understanding something like brain fatigue, and somebody might not be able to make it through, say within your home care agency, we have a PT, and then we have skilled nursing coming right after, or you have a homemaker coming, and then or somebody had to go to the PCP for an appointment, and they come home and have to interact with a homemaker, a personal care person, then that person might have difficulty processing that second part of their day because of brain fatigue. They might need a nap, and they might need cognitive rest in between. So being aware of things like that. Also, a big thing that goes along, I think, with headaches and migraines as well is changes in sensory function. So a lot of people will be suddenly hypersensitive to light and sound as a result of their brain injury. So thinking about the volume of your voice, thinking about where you're meeting people, if people really need lights to be dimmed, or they need lighting to change in their house or something like that, things to think about. In terms of cognitive effects, again, if we think especially, I always think about that frontal lobe, because really so much of our important executive function, or all of our executive functioning really is there, and this is how we're going to be able to process information and organize information and remember information. So thinking about working with patients and how we can help to make some accommodations in terms of memory aids and calendars, and using notebooks and using reminders, and if especially for in a home care setting, if somebody is having trouble remembering that a person from a home care agency is supposed to have an appointment, maybe that has to do with some memory deficit that happened as a result of the brain injury. You know, could the agency come up with a plan to call 15 minutes before, and maybe even then they might forget, you know, but, you know, in order to kind of help that relationship between the agency and the survivor, and to respect that these are cognitive changes that could occur. And lastly, I think emotional effects of a TBI are really something significant to think about. People, after the fact, there could be some organic changes that happen. So because of where an injury occurred, there could be organic changes to the brain that cause problems with mental health after the fact that disrupt hormone and it's not coming to me. I'll think of it in a minute. The different levels of chemical transmitters within your brain can cause organic problems with mental health, but also the actual event of having your life change because of a brain injury can cause some of these mental health issues. And definitely personality changes that occur because of organic injuries, and then how that affects interpersonal relationships. So something that the Brain Injury Association could do, and that I can do for you if you're working with someone with a brain injury, is if someone's experiencing some emotional effects, give us a call, get that person to a support group, and we'd also be able to provide lists of therapists, counselors that work specifically with brain injury survivors in the community, which I think is important. And I know we're running out of time here, but I just really want to make sure I emailed everybody. This is the last piece of the presentation, and again, I'm cognizant of the time, but I emailed everybody, or Megan emailed for me, a copy of the statewide head injury program, the SHIP application and brochure. I think it's just an application, but I just wanted to just make sure people were aware that in Massachusetts, the Mass Rehab Commission is the leading state agency for brain injury services, and we do have the statewide head injury program as part of that. This is a services that provide a much higher level of case management than an ASAP is able to do, that a private home care agency is able to do. They're able to bring someone to a doctor, take notes, bring them to the pharmacy, and pick up their medication and come home and fill, not fill their med box, or help them to organize their medications at home, help them to organize bills. It's a high level of case management if people are found eligible for this. So this is traumatic brain injury only. But I think a super important resource. There's also the brain injury waivers, and again, this is such a brief overview that I think what I want everyone to walk away with is that by calling the Brain Injury Association for a particular survivor, a particular patient that you might be working with, or even a family member or a friend, then I would be able to go over what might be appropriate for somebody to have. And all these services are free. They're state services, so they're free, and they're I think can be invaluable to somebody that's had a brain injury, and not everybody knows about these services. So I did also send a application for the waivers, the acquired brain injury waiver. I don't think this is as applicable to home care because of the eligibility requirement. Someone would have had to be in a skilled nursing facility at the time they applied. But I'd be happy, maybe a friend or a family if you're interested. But again, all these programs, I'd love to be able to just make sure you're aware of them, but also to be able to extend to you. Please call me if you're working with someone with a brain injury so that we can talk out what would be some good resources to share with them. And again, these are a way to connect with services for the elderly and disabled. So I just included the number in the website to go on and poke around. What's great about this website is you just plug in, like, what's the name of a Massachusetts town? Fall River, and someone with Alzheimer's, and it'll spit back the agency that you should be calling. And then this is me. So this is my contact information. This 844 number we created to track who's calling me. You're welcome to call the main number. We, in our information resources, again, it's a free service, information and resources, and we're able to connect you or a survivor to support groups and to information and resources related to brain injury. And my more detailed contact information, which I believe everyone will have from the email as well. So, but I hope people do utilize the resources and reach out. I'm going to email people on the continued education. We won't take time on that now. I'm just going to see if there's any questions. And I think everybody, I hope there was, sometimes this information, it's just so much that I don't expect everyone to walk away with everything, but please just call and ask questions if you're interested. Megan?
Thank you very much, Liz. So as she mentioned, if you have any questions, you can write them in the sidebar that you have. There's a tab that's labeled questions. You can type them in there, and then we can address them. While we're waiting, in case any of you do have questions, obviously Liz kept mentioning that her contact information is here. You can obviously email her or give her a call at any time. This was recorded, so if you want your staff to listen to it or you know of someone who might be interested or anything of that sort, I will send that link out to everyone once it's been processed. That should be probably by the end of today, if not then tomorrow morning at the very latest. But I do thank you all for calling in today, and Liz, I thank you very much for this presentation.
Well, thank you, Megan. I really appreciate the opportunity.
Great. Doesn't seem like we have any questions now, but I also know that a lot of people might contact you afterwards. So with that, I hope you all have a great rest of your day, and thank you.
Thank you very much.
Bye.